My talk today is the evolving landscape of advanced prostate cancer treatment. And as you guys had kind of highlighted on that previous talk, I hope this will be kind of a nice mix of a few different topics. And again, we can branch out into kind of tangents with all the specific therapies themselves. So my objectives today, I first hope to get into a few kind of introductory slides about the greater context of prostate cancer, talk a little bit briefly to set the stage about the stages of prostate cancer. First, briefly making mention of early stage disease and what our treatment modalities are, and then kind of that's a segue into more advanced disease and what different treatment options we have. This is a variety of different things, and honestly, an expanding list. It's a very confusing landscape, I'd say, for both patients and providers to kind of navigate. There's a lot of unanswered questions. I hope to briefly talk a little bit about genetic testing, a brief primer in terms of what we mean when we're talking about genetic testing, and ultimately what that can mean in terms of the different treatments that your physician may offer. I'll then briefly touch on supportive care that's a part of advanced prostate cancer, but sometimes early stage disease. And then I hope to kind of have a brief kind of few moments in terms of where I foresee things heading and hopes or changes that will happen in the future. So a little bit about epidemiology with respect to prostate cancer. Prostate cancer is the most common cancer, non-skin cancer in males, accompanying, and this is statistics from the American Cancer Society, encompassing about 29% of all new cancer diagnoses, close to 300,000 men diagnosed per year. It's the second leading cause of cancer death in American men, only behind lung cancer. Lung cancer certainly is more prevalent in this part of the country with tobacco use, but you can see prostate cancer there, kind of right behind it. About 1 man in 41 will die of prostate cancer. The death rate had declined from about half from the 90s to the late 2010s. And that was a consequence mostly of early detection and advances in our treatment. Since then that pace has slowed a little bit, reflecting the rise of cancers found in more advanced disease. And then the right portion of the slide there talks about the incidence with a few red arrows there. You'll see it's the prostate cancer line in the maroon colors is quite a dynamic one with that really precipitous rise in the 80s and 90s. A lot of that was driven by TURPs or transurethral prostate biopsies. That was becoming a more common or in-trend treatment for BPH, or benign prostatic hyperplasia. And so they would incidentally find some of these prostate cancers just by the biopsy itself. They then developed a lab test, the PSA, kind of in the 90s and became more in vogue, so to speak, for primary care providers screening men for prostate cancer. The U.S. Preventive Task Force kind of dampened some of that enthusiasm initially. So we were diagnosing men and probably a lot of early stage disease up in the late 90s, early 2000s. They kind of did a flip-flop, so to speak, in terms of them less recommendations, so to speak, in terms of PSA as a screening tool, and they kind of changed that a little bit. So you see that more recent rise, a lot slower, obviously, than the previous trend. There we are. As far as risk factors for prostate cancer, so age is the most powerful. It's rare to be diagnosed with prostate cancer in before the age of 40. About 60% of men that are diagnosed are over the age of 65. As far as ethnicity, it's more common amongst African-American males, and usually with more advanced stage disease in that category. Less commonly with Asian and Hispanic Americans. Having a first-degree relative with prostate cancer increases your risk, so a family history, and that can otherwise encompass genetic or inherited syndromes. You guys probably have heard of BRCA1 or 2, that being amongst others, increasing risk of prostate cancer. And then there's some interplay or thought of interplay with diet, with red meats, high fat and dairy products, increasing the risk of prostate cancer. Men who have fruits, whole grains, and vegetables as a predominant part of their diet, presumably being at a lower risk. I always have a little bit of pause with some of the dietary studies. They're honestly very difficult studies to conduct. There's a lot of confounding factors and things that you just really can't capture. I think there's been some debate truly as far as how diet with men with prostate cancer really interplays with their survival or how they do. Having said that, though, I think the healthier that men or patients can be while they're undergoing treatment really at any stage is beneficial anecdotally as far as how they will do. I guess I'll stop there briefly. Annette, was there, or Jim, was there any questions in the chat so far?
No questions yet.
Okay. So then moving on and talking about stages of prostate cancer, and I understand this isn't the focus of my talk, but briefly to set the stage again, localized prostate cancer, really there's kind of three different options that a provider may give you. And a lot of that is really, really personalized ultimately, depending on the characteristics of your tumor. I'm sure you guys are well-versed, maybe some not as much, about a Gleason score, which really captures the different histology or what the cells look like under the microscope, what the predominant histology is versus less predominant. You may get a grade with your prostate cancer, and the PSA is certainly important, how high that level is. So three, again, options in terms of what providers may offer. Surgery or a radical prostatectomy done by a urologist is certainly a viable option that some men undergo, my dad included. Radiation, and there's a wide variety that I won't necessarily get into in terms of what that may be. And then, active surveillance may be a not unreasonable option in, let's say, older men that have very low risk disease. Not one of these treatments really stands out, really providing a huge survival benefit of all prostate cancer amongst the rest. So it's really very much an individualized approach. I'd say a lot of these patients I do not see as a medical oncologist, but I would say there are some that I do, namely with respect to radiation. This is where it may get very confusing in terms of what different doctors that you see, because a lot of what I do as a medical oncologist, urologists do, and even some radiation oncologists do. But there would be, specifically with radiation, if that's the primary local treatment that you receive for your prostate cancer and you have high risk disease, there's been some newer data to suggest that you actually would benefit from an injectable medication or ADT, which again, I'll get into in later on in my talk, as well as potentially an oral agent, which interplays or downregulates some of the hormones. And the hope is that decreases your risk of recurrence later on. To contrast that, so what is advanced prostate cancer? That's ultimately where prostate cancer that was previously confined to the prostate is now spread beyond the prostate. So that in some cases, early stage disease can still encompass regional lymph nodes, but otherwise you're talking about spread to namely bones. And then less commonly, it was spread to what are described as visceral organs that could include liver or lung, commonly as it does with other cancers. That usually portends a more aggressive variant of prostate cancer. I get asked this question a lot, what types of symptoms should I be on the lookout for if there's any concern that I, have advanced disease? And that can be really a difficult question to answer because that can be quite variable depending on where the stage of disease is. So big red flag symptoms that I always counsel patients about, certainly worsening urinary symptoms if you still have a intact bladder or prostate, worsening pain that just builds and builds and builds and just doesn't get any better without any clear, traumatic event. But you may feel otherwise kind of nonspecific symptoms, really vagueness, fatigue, unintentional weight loss, just not feeling like yourself. And in some cases, advanced disease really can only be picked up by a PSA. Advanced disease may also be considered what's described as biochemical recurrence, where you have a very elevated PSA, but your scans don't show any evidence of any cancer. Next, kind of talking about the classes of treatment. And I thought I would kind of start with a foundation, so to speak, and kind of build up from there. So prostate cancer is a little bit unique in that it's very, very sensitive to androgens, specifically testosterone, kind of the equivalent of what we see in the oncology world with breast cancer. 95% of the testosterone production comes from the testicle. There's another smaller portion or amount that comes from the adrenal gland as well as other tissue, about 5%. And a big pillar of what we do with advanced prostate cancer is we take advantage of the fact that it feeds on testosterone. So when we describe hormone therapy, that doesn't mean elevating hormones. It actually means shutting down production of testosterone. Another term, and we like to have many names for the same thing in medicine. Androgen deprivation therapy, or ADT, is another name for essentially the same thing. And to walk you through, and I don't want to get into the weeds, so to speak, of this too much. I hope you guys appreciate my nice artistry here. I was an artist in a former life, and then I went to medical school. But there's this complex cascade of hormones that start in the glands near the brain, the hypothalamus and the pituitary, and that cascade ultimately leads to testosterone production from the testes. As I said, less percentage-wise coming from the adrenal gland, and that feeds into the prostate. So we again can harness and use that to our advantage. And this is where GnRH, which is the hormone produced by the hypothalamus to the pituitary gland to stimulate that LH luteinizing hormone to produce testosterone, we have what are described as GnRH analogs that in essence cuts down the production of LH and therefore testosterone. That can be done in one of two ways. So we have two categories in that same class of drugs. We have GnRH agonists and GnRH antagonists. And they both accomplish the same thing in terms of what they ultimately lead to, which is testosterone suppression. But they achieve it in kind of different ways. So GnRH agonists, and I'll get into this on my next slide, send a powerful signal to the pituitary that ultimately desensitizes or tires out the pituitary gland to the point where it just doesn't acknowledge that signal anymore, and therefore produces less of a consequence of that signal. So that again is a GnRH agonist. So it antagonizes agonist, if I misspoke there. We also have GnRH antagonists, which is in essence kind of blocks that signal. It works in a different way. And there's a few different options. There's actually a newer option that's available that wasn't available even a couple of years ago in that category. One thing I'll say to kind of distinctly divide the two, so the GnRH agonists, with that initial powerful signal to begin with, you can actually get a brief flare of testosterone. So specifically, I use Lupron quite a bit. That's an injectable shot, a GnRH agonist. That's often, depending on if there's a very high PSA, that's coupled with a pill, just for usually a brief period of time, whether that be a few weeks. Biclutamide or Casodex is a very low level or low potency anti-testosterone. And what that's meant to do is actually decrease or blunt the initial flare that you have with testosterone before it downtrends. That can ultimately, that flare could in essence lead to a flare of your prostate, so causing a rise or uncomfortable symptoms with urinary retention in patients with more severe disease. And a lot of this is more theoretical, so to speak. If a man had really, really severe bony disease, you could even worry about if there was a big bulk of it on his spine, even spinal cord compression with that brief testosterone flare. So this next slide kind of gets into a little bit more of the details about what the different options are for ADT or androgen deprivation therapy. So GnRH agonists come in many different flavors. You guys may have seen some of these names before. Again, so confusing. And on the oncology world, we have 2 names for every drug. Think of these as kind of different names of, in essence, the same thing. Eligard, Lupron, or leupluride, glycerolin, Zoladex, Trelstar, kind of Coke and Pepsi. They, some insurances, prefer one over the other. They can be done in different frequencies. These are all injections. The GnRH agonists can be done monthly, can be done every 3 months, even up to every 6 months. The GnRH antagonists, so to briefly talk about that category, there's 2 different options that you have. There's a thought that as far as the way that these drugs were studied, they present potentially a lower risk of some cardiovascular disease. Firmagon is the injectable. The one limitation with that is it has to be monthly. So there's no flexibility beyond that. But Orgovyx is the kind of the new kid on the block. It's a pill that you can take. I've had some limited experience, I'd say, so far with this pill. The trial really showed quite impressive depression of testosterone really rather quickly. And again, in this general category, it's supposed to potentially decrease some of the cardiovascular risks that you talk with this category of drugs. As a benefit, right, men have a little bit more control over, taking the medication, and if they have any side effects, they can take it off. And that's a lot faster of a relief of some of those symptoms, as opposed to some of these injection medications where if you get a shot every 3 months, that effect lasts for 3 months. Whereas the pill, there's a little bit more flexibility that you may have. With anything new, of course, it tends to be expensive. This, from an insurance perspective, does give us at least a big barrier, but St. Elizabeth, as well as other bigger hospital systems, have a robust department with pharmacists that kind of try to guide you through all the hoops that you have to go through with getting these medications at a reasonable fee that you can actually afford. Talking about this class of drugs in terms of just overall side effects, you can get hot flashes, as I affectionately call menopause, equivalent to kind of what women experience with menopause. Mood changes is not uncommon. Loss of libido, probably the most common complaint that I get from men is fatigue, generalized kind of weakness, or not feeling as strong as they did before. And then kind of longer term risks that we worry about ultimately is decreased bone density, accelerating that natural process that happens, potentially putting you at risk of developing osteoporosis at an earlier age, and ultimately increasing the risk of diabetes or cardiovascular disease, which inherently, as I talked about in the beginning of my talk, is, prostate cancer is a cancer of older men, and older men may have some of these pre-existing conditions, which certainly, you don't take lightly in terms of trying to balance the toxicities and ultimately the benefit of your treatments. Ultimately, so this is a kind of the pillar of prostate cancer. We add things to it. So this was really all we had decades ago in terms of what our options were. That eventually stops working, as many cancers do. They find ways to grow and resist what you're throwing at them. That commonly can last, on average, a couple of years. Obviously, much different in terms of what the context of how you're using it is. As you may be using it in ultimately earlier stage disease. When that stops working, when the PSA rises, the cancer grows despite you suppressing the testosterone that's described as castrate-resistant prostate cancer. So you may hear that term thrown out a bunch with different doctors or even in the literature. Interesting, it's something always to be cautious of. So sometimes, although rarely, you'll think you're suppressing testosterone. The PSA is rising. A man is on an injectable, an ADT. It's important to always check a testosterone, because you can certainly be fooled when you're not adequately suppressing that testosterone. You're not truly adequately treating them. But this is kind of where my piece of the puzzle comes in, is that we add things to ADT ultimately to counteract that alternate pathway that testosterone is produced, and ultimately using different ways to fight the growth of cancer cells. This depicts kind of nicely a broad speaking, a view, a 100,000-foot view of what we have available in our arsenal. As you can see, even in the last about 10 years, things have really expanded quite a bit. So docetaxel, even about 20 plus years ago, that was really all we had beyond ADT. Newer agents, so other chemotherapy agents came to be. Provenge, in 2010, we developed a rapid amount of all these oral agents. Radium, wasn't that 2013 doesn't seem too far away. Some of these newer agents, again, using unique mechanisms, olaparib, which is a PARP inhibitor, which I'll get into in these next slides, and ultimately lutetium, Pluvicto, was just recently approved, and that's quite exciting in terms of using kind of a novel therapy. The issue really is the access to the drug. So first, I'll talk about chemotherapy, and I intentionally kind of kept this rather brief. But this kind of just is a sticking point. I didn't want to riddle you guys with all these various texts. But the first drug here, the mitoxantrone, is really here for more historical purpose. So this was FDA approved back in '96. I didn't even include that in my timeline. But it's amazing to think, this drug probably wouldn't be approved with the whole rigorous process that we have. But that improved quality of life, but did not improve survival. So men, as a result of getting this medication, felt better, but they didn't live any longer. And based on that data, the FDA felt compelled that they should approve the drug. So again, we've come a long way since that, 1996 FDA approval. Taxotere was the first treatment to show improved survival in this advanced or castrate-sensitive or resistant, rather, prostate cancer. It's still a good tool that we're using, and we're using it in kind of different ways, but that is it's still a common chemotherapy drug that we use in prostate cancer. Carbazitaxel is something that we would use if a patient progressed or the cancer grew despite them using Taxotere. A brief kind of a discussion about these medications. So these are traditional IV chemotherapy medications. There's a whole laundry list of side effects that we kind of talk about and counsel patients before they're going to get any of these drugs. Them being IV medications, a lot of patients preemptively get what's called a portacath, which is a little button that fits underneath the skin and typically in the chest, that acts as kind of a reservoir and access point for some of these IV medications. And we actually use a specialized needle to access that for their treatments. Some of these drugs can be used with just peripheral IVs, but chemotherapy tends to be harsh on the blood vessels. I'd say we've come a long way in terms of how we support patients through treatment. We have a lot of medications that we can combat, say, nausea and vomiting or diarrhea that they may have with treatment. Neuropathy or a pins and needle sensation can happen with some of these treatments. The big other thing we worry about with traditional cytotoxic chemotherapy is knocking down blood counts. The white blood cells are really the biggest ones, the ones that we care about probably the most, and and if those are low, patients' defenses are down and they're more susceptible to infections. So I think we have several pamphlets kind of plastered all over our clinic. If you have a fever, it's important that you tell us, because you can get really sick really quickly. And I've unfortunately seen patients in training that waited too long and ultimately were critically ill, if not passed away as a result of waiting. So it's critical ultimately that patients get, some of these infectious processes treated if they're neutropenic or their white blood cells are low. We're also constantly checking the liver and the kidneys because those are the organs responsible for getting rid of all the toxins that we give you. So again, chemotherapy has a useful role in prostate cancer, but should be used judiciously ultimately because it carries a good amount of side effects. And this is probably a therapy class that has more side effects certainly than others, especially in the prostate cancer realm. But we use chemotherapy, traditional chemotherapy, even though we have all these newer classes of drugs, so it still has a role. Beyond that, though, as the timeline kind of depicted, we have some of these newer agents that we have, and this is where it honestly gets confusing as a patient and as a provider in terms of what drugs you use. A lot of this is ultimately the indications of how the drugs were approved, patients' familiarity or providers' familiarity and comfort with using the medications. And ultimately what it always boils down to is money, right? So insurances have certain preferred drugs ultimately. And it's astounding the copays that are initially given to the patients. I mean, you're talking tens of thousands of dollars per month for a supply, which that's not common for really anyone to be able to afford that. So again, this is where a robust pharmacy and prior authorization comes into play, and they offer some financial support. So the first drug I'll talk about is Zytiga or abiraterone. This blocks the synthesis of the tumor testosterone in the tumor itself, the testes, as well as the adrenal glands. It's taken with a low dose of prednisone. And this I'll get into in the next slide, but ultimately that's a consequence of where it acts in the adrenal gland. As a result of it blocking enzymes, ultimately some of those enzymes result in a buildup of a byproduct that can cause a very interesting, unusual case of a kind of a similar adrenal insufficiency, or the adrenal gland not working as it should, which can have certainly a consequence. The traditional dosing is 1,000 milligrams once daily. And again, with the low dose, typically 5 or 10 milligrams daily of prednisone. There's this off-label use of the drug. This is an asterisk on the last line there. It can be given as a lower dose if it's administered within 30 minutes of a low-fat breakfast. So that really plays to the absorption of the drug. So you're getting essentially the same therapeutic dose, but more absorption with a low-fat diet. I had one patient, unfortunately, he was confused with the low versus the high-fat diet. So he was actually taking high fats with the drug, which meant he was even getting less of the drug than what would be the 250 or the lower dose, which was unfortunate, but we clarified shortly after he started telling us what he was eating. This slide depicts, so a little bit of a busy slide, which I apologize about, but think of this whole slide as this is all in the context of the adrenal gland. It's the gland that sits above the kidneys. And abiraterone acts at really two places, cutting off the precursor from going downstream to ultimately lead to testosterone, but also cortisol. So that's where you get that you get that decrease of cortisol ultimately, and that increase of byproduct or ACTH, which is a hormone. And so you need steroids to kind of compensate what your adrenal gland, your natural gland that's producing steroids, should be doing. So that's a little bit of a unique piece with Zytiga. So it has to be paired with a steroid, which you can imagine is not necessarily the best choice for a patient that has issues with their blood sugars, they're insulin-dependent diabetic. So this is where the individualized approach comes into play in terms of what agent you ultimately use. Talking again, moving on to some of the other agents or options that you have in the same class of drugs. I guess to take a step back, so Zytiga is approved in metastatic, castrate sensitive, as well as castrate resistant prostate cancer. Castrate sensitive means it's still sensitive to the effects of ADT or androgen deprivation therapy. So in this class, you have really three options. Darolutamide is the newer kid on the block, so to speak, in terms of the newest drug approval. I'll get into the mechanism in the next slide of how these work and how these are different than the other drug. But ultimately, they all work very similarly. Darolutamide has probably the least amount of penetration into the blood or brain barrier, which really plays into the risk of side effects. So with these class of drugs, I'd say specifically, most notably enzalutamide, there is a risk of falls or increased falls with these drugs, as well as seizures. So if patients have some underlying issues with, say, their gait to begin with, maybe not necessarily the best choice. If they have an underlying seizure disorder, again, maybe not the best choice. Added benefit, though, they don't necessarily need to be paired with any steroid, which is big. One of these slides here kind of talks about how they work, and again, the next slide is a nice pictorial as far as how that works. But in essence, this acts at the cellular level of the prostate cancer cells, kind of really a three-pronged inhibition. It inhibits the binding of the androgen, the hormone, to the receptor on the outside of the cell. It inhibits the translocation of that receptor into the nucleus, and ultimately inhibits the receptor's interaction with DNA, ultimately causing cell death, prostate cancer cell death. And this is the slide. This talks about really how that acts at the kind of three different levels. So the purple visual there is the prostate cancer cell. The testosterone is pictured in T, and then it blocks that interaction with the androgen and the receptor itself. It blocks its interaction and translocation from the cytoplasm into the nucleus, and ultimately its interaction with the DNA, leading to, again, cell death, decreased replication amongst the cancer cells. Getting into a little bit of a change of gears, so radiopharmaceuticals is another class or option that we have in prostate cancer. Radium-223 has been around for a good period of time. Xofigo is the brand name for this drug. It's a bone-seeking radioactive element. It's limited to men with symptomatic bone metastases without any evidence of any other disease. So that would include lymph nodes, other organs, liver, and lung. It's an IV treatment, typically given by a radiation oncologist or potentially a radiologist. It's given every 4 weeks and ultimately for a maximum of 6 doses. I'd say for the most part, fairly well tolerated. So it delivers a radioactive element into the bone. It's kind of like almost like a calcium analog. And it emits a really high photon or energy inside the cell, but over a very short distance. It can have some side effects. The big ones we worry about is it can be incorporated or absorbed into the bone marrow, which can lead to cytopenias or low blood counts, and ultimately can be absorbed into some of the gastrointestinal system, the GI tract, which can lead to some GI distress, nausea, and vomiting. This ultimately has been effective in terms of reducing pain and also improving survival. So men live longer as a result of this medication. And this is usually something that's reserved for a later line of treatment ultimately. And I'd say the big limitation that I have in terms of men exploring this option ultimately is they have too low of blood counts to qualify for administration of the drug to begin with. The new kind of exciting drug that I'm sure you guys have heard a whole lot about, Pluvicto, the PSMA radioactive isotope, the radiopharmaceutical that was approved in March. This is approved for men that have had chemo before. They've had one of those oral agents that I talked about and are resistant or refractory despite any of those. And again, metastatic and castrate-resistant prostate cancer. Of note, they typically have to have that PSMA PET scan to begin with and be positive. This carries a much better side effect profile. I'd say it's much better tolerated than radium, to contrast that previous slide. The side effects can include low blood counts, rarely some kidney toxicities. The big thing you worry about, it's interesting if you guys have ever seen a PSMA PET scan, but it lights up in terms of some of the salivary glands as well as some other glands. So you can actually get some dry mouth or swelling or pain related to ultimately that off-target effector uptake. And the slide, the picture there depicts the radioactive isotope paired with an antibody that in essence kind of delivers its specific payload to the PSMA, which is a target on prostate cancer cells, incorporates it into the cell, and that radioactive isotope ultimately degrades the DNA, which causing cell damage and cell death. I guess a little bit of a tangent, PSMA PET scans are becoming all the rage, really changing what we really think about in terms of staging imaging with prostate cancer. There was another PET scan, an Oxymin PET, you may have heard before, that's kind of gone out of fashion with this newer, more exciting and more specific PET scan. Bone scans and paired with CT scans are, again, something that we use in certain circumstances. But again, if we have access to a PSMA PET scan, that's a much better picture, more specific picture of where the prostate cancer is. And interestingly enough, urologists are now using this as part of their staging and really identifying a lot of what they thought initially was early stage prostate cancer, which is maybe more advanced. So those men maybe aren't going to surgery or ultimately radiation. I'd say with any new tool, there's ongoing questions. I'd say some of these PET scans are kind of difficult to interpret with maybe a questionable finding. What do you do with that questionable finding when everything else points to a man having localized prostate cancer? So I think that using that more and more will develop more data ultimately in terms of how to use it. And that's where it's really the Wild West in terms of how different physicians are utilizing the test. I'd say in terms of Pluvicto, it's unfortunately hit some snags since it was approved in terms of access. So it's used and has been used quite commonly outside the United States, but the production and administration has really been a big barrier. At St. Elizabeth, at least, we do not currently have access to the drug. I know a lot of patients were trying to get ultimately on trials to get the drug to begin with, but I think that's hopefully going to improve soon. Cellular immunotherapy is also something we consider in metastatic or advanced prostate cancer. A very unique mechanism and ultimately a unique processing feature with this medication. So it was one of the truly first what we describe as immunotherapies. It's a therapeutic vaccination. So as far as the way it works, and in the local area here, it's typically Hawksworth that would do all this production, but you would get a shot that would boost up your white blood cells. They would then draw some of your blood out into a machine and pherese out some of those white blood cells. They would then collect those in a lab and introduce a prostate cancer antigen or a target with those cells. Those cells are cultured over time and grown and ultimately reinfused back in the patient. And this, from a tolerance standpoint, for the most part, is fairly well tolerated. It's typically reserved for patients that have slowly progressive metastatic castrate-resistant disease that is asymptomatic. To be honest with you, this is not a tool that I use all that often. I'd say this may be something more so that a urologist may offer to you. It's interesting the way the drug was approved in that it didn't necessarily correlate with PSA being a good marker to monitor the benefit of the drug. So in my mind, it's always been a confusing thing as far as how to really see the true benefit. And again, that's why it's limited to such a unique facet of prostate cancer. I think they sent me maybe a few questions about this drug specifically. There was one that somebody mentioned its use, or if I'd ever heard of it being used in early stage prostate cancer. I did look this up before the talk. It sounds like there was a trial that did show some maybe encouraging things in terms of prolonging how quickly a PSA went up, but didn't necessarily, they didn't take it beyond that. It was kind of a trial that maybe thought there might be a use for it, but it didn't seem like it went beyond that stage. So it's not something that we typically use in early stage prostate cancer. So a little bit of a tangent talking about genetic testing, which we really push amongst a lot of our patients, prostate cancer patients included. We have a whole genetic clinic that is run by one of the physicians that I work with, Dr. Brooke Phillips, as well as several geneticists and genetic counselors. And I think it's a big, important thing amongst all of oncology. And with that being kind of everything becoming more personalized. Whoops. I apologize. So as a brief primer, whenever we talk about genetic testing, I always find that there's a lot of confusion about what we actually mean. And really, there's two categories of genetic testing when we talk about genetic testing. So there's germline genetic testing, and this would typically be done by a genetic counselor or can be ordered by a cancer doctor. Ultimately, when we're talking about germline genetic testing, we're talking about something hereditary. So this is present in all your cells. You were born with this mutation or abnormality. This can have really, it can be consequential for other family members. So this can prompt, if they identify a mutation, say a BRCA mutation, that can determine what screening you may need with certain types of cancers. That's all kind of very closely detailed in our governing body, the NCCN, or the National Cancer, this governing body ultimately has all sorts of resources. I would encourage you guys actually to log in and make an account if you've never heard of it before, but you can go to nccn.org, and there's a whole plethora of prostate cancer information, but also other cancers as well, and everybody has access to it. It's free. But in essence, that even has details about certain genetic syndromes and how we screen at certain ages with certain tests for different cancers. So this can really have a profound effect. I often get this question with males in their 70s or 80s. They say, why do I need this testing? You know, I'm already past any of those ages that we're trying to prevent cancers. And I argue, you know, you may not, but other family members, if they find something, may be greatly benefited from that. I'd say that can, though, still have some consequence, and I'll get into this in the next upcoming slides, in terms of what your treatment may be. To contrast that, we talk about somatic genetic testing, and this is an acquired mutation. So this is something you've developed. And when we're talking about somatic mutations, we're typically talking about genetic mutations in the tumor cells, in the cancer cells. And this may be, you may hear this in other terms, molecular testing, next generation sequencing. That's all kind of talking about that same category. And there's multiple different companies that in essence do this. We send out tissue typically, say via biopsy, to some of these outside institutions, outside companies. They process this information, and then they give this back in terms of a report. And ultimately, again, that's looking for mutations that your cancer may have that may dictate how we treat you or your treatment options. Specifically with one of those treatments, talking about targeted treatment, PARP inhibitors is something that's been used in some cancers, prostate cancer included. Now, there's two currently that are typically used. Lynparza or olaparib is something that I use more commonly. So PARP is a protein that in essence, and I have a picture off to the right there, it helps repair your DNA. And there's certain cancers, certain people that have an Achilles heel where this is somewhat limited. And this really plays upon that. So they inherently were born, or their cancer has a mutation that in essence limits their cells' ability to repair from DNA damage over time. The PARP inhibitor ultimately, kind of that last crutch, so to speak, that they had, that one pathway, it cuts that off and ultimately leads to cell death. This is approved in castrate-resistant prostate cancer with certain germline or even somatic mutations, so it can actually be both, which includes BRCA1 or 2. There's also some others that I didn't necessarily depict on the slide that most insurances will cover. For the most part, a fairly well-tolerated drug. Patients can get some nausea, an upset stomach, some diarrhea. And then the other thing we worry about is low blood counts. There's a rare complication in this class of drugs, actually, for it causing blood cancer or acute myeloid leukemia. Again, not something commonly that we see, but it is a possibility, although a rare one. So this is a drug class that, again, is used in the metastatic setting. Again, this is all paired with ADT, so ADT is continued. I forgot to mention that. So to take a brief step back, whenever a patient's progressed beyond that initial testosterone blockade, we continue that therapy regardless of the other therapy that we add to it, which is certainly important. So this class of drugs, again, newer to the block, is an option for a unique portion of prostate cancer patients. There has been some interesting trials recently. There was a trial presented at the GU ASCO, which is in San Francisco every year, typically in February, with the question about adding those other second generation androgen deprivation pills to PARP inhibitors as a possibility of a kind of combination therapy. And then there's been a big question about whether these drugs can be expanded into a greater population of men that, say, don't have this mutation available, or this mutation inherent in their cells or cancer cells. I'd say that I was not as impressed with their data when they presented all comers or everybody with the PARP inhibitors. But the trial is all preliminary. So we can't say that men live any longer across the board as a result of this. So I think we'll be waiting in the upcoming years to see how this trial kind of pans out. Checkpoint inhibitors, I'm sure you guys have heard in the world of oncology, something that we use in a lot of different cancers. This is probably what most people think of when they think of immunotherapy. What I describe patients, so the immune system is a powerful tool. The immune system outside of it, fighting infections and foreign organisms, also attacks cancer cells. But cancer cells are smart and they evade the immune system. They have means where they can block the signaling pathway that ultimately causes your cancer cell to be alerted, or the immune system to be alerted to your cancer cell. These drugs kind of takes the foot off the brake, so to speak, of the immune system. So you get a kind of immune activation for everything, including the cancer cells. Now, again, different drugs, they work in a different way and therefore have a different side effect profile. You worry about too much immune stimulation. So collateral damage, your immune system attacking yourself, much like an autoimmune disease would. This can be a variety of a laundry list of what I describe as itises, or uncontrolled inflammation. This can be very mild. Patients can develop a rash or a dermatitis, as simple as we put a little bit of a steroid cream on it and it goes away and there's not really much of a problem beyond that. And in some cases, it can be quite severe. So patients can get pneumonitis or inflammation in the lungs causing severe shortness of breath, or colitis, inflammation in the colon causing rip-roaring diarrhea, ultimately to the point of needing to be hospitalized or even life-threatening. If patients experience any of those side effects, we typically put them on high doses of steroids to kind of put the brake back down on the immune system. But a very powerful class of drugs. Ultimately, this is an option in prostate cancer, although a limited option. So this is a small population of prostate cancer patients that have a high number of mutations in their tumor. Something you may also hear is MSI high or microsatellite unstable, MMR deficient, which stands for mismatch repair. In essence, these cancer cells lack kind of a deficient or a mechanism, so to speak, of combating the immune system. And a high number, what I describe to patients is a high number of mutations kind of acts as a little bit more of a target for the immune system. And this can be associated with some genetic syndromes. As far as a total, again, rare in the greater world of prostate cancer, this encompasses maybe 5%, if not less, of all prostate cancer patients that would be potentially candidates for this drug. And again, 3 that I depicted there, Keytruda and Opdivo, I'm sure you guys have seen commercials on TV about. Those are used commonly in many different cancers. The new one on the block, Durvalumab, again, is approved in this broad class of characteristic prostate cancer that falls under, can be other cancers too. In the lay press, you may have heard this drug used in colorectal cancer, where in a very early stage clinical trial, it had close to 100% response rate, which is kind of unheard of in the early clinical trial world. So this is a drug that's used now and approved in kind of different cancers that have this specific profile. Again, to change gears, a little bit of a shift. So outside of a tumor-directed treatment, we also talk about supportive care. And in the world of advanced prostate cancer, when we're talking about supportive care, really that has to do with bone health. So you have this loss of bone mineral density that ultimately can be a consequence of just aging, but also we add to that risk ultimately with androgen deprivation therapy itself, and ultimately the presence of cancer, which weakens the bone. And what we worry about in this setting is ultimately risk of fractures and major fractures of that. So we talk about a few different options in terms of different drugs. I'd say these are, I don't want to get bogged down in the weeds per se. These are names to be familiar with. Zoledronic acid can be in kind of 2 flavors, Zometa and Reclass, depending on the dose of the drug and ultimately how it's used. Both of these are called bisphosphonate therapies, and ultimately they counteract cells in your bones called osteoclasts that kind of break down bone. Denosumab acts a little bit differently. It's actually an antibody that interferes with these cells, these osteoclasts. In both of these classes of drugs, I'd say they're well tolerated. There's used in a number of different indications. What I counsel patients is it's important that they're taking calcium and vitamin D with it, because it kind of sucks the calcium into the bones, and you can sometimes get a low calcium as a result of the medications. There's also a rare risk. To be frank, I haven't actually seen this complication, but some patients can actually get osteonecrosis of the jaw or breakdown of the jaw. And so what we counsel patients before initiating this drug, that they see a dentist if they've never seen a dentist before, or if they're falling regularly, to get kind of dental clearance. And it's important that men or patients don't get any major dental work while being on this medication. And lastly, kind of a little piece about the future here. So where I see things progressing or happening, I think there's a lot of ongoing questions as far as where we will head. There's been some newer literature to suggest if 2 drugs are great, then 3 drugs should be better. So there's been what's described as a triplet therapy. So that incorporates chemotherapy, usually docetaxel is what we're talking about when we're talking about this, an oral agent and a shot altogether. And this is specifically based on two newer phase 3 trials that were played out and described in some of the conferences. This would be in castrate-sensitive metastatic prostate cancer, and it's usually more beneficial. I recommend it in patients that have a larger bulk of disease, or what's described as high volume disease. When we describe high volume disease, briefly as a definition, we're talking about usually visceral disease. So that could include lung or liver. It also can include bone if there's several different bone spots involved. So a very aggressive regimen, a lot of obviously side effects with 3 drugs as opposed to just 1 or 2. Piggybacking on what I described immunotherapy, I think we're just scratching the surface of really what the immune system can do. We're developing and modifying all these new cellular therapies, which includes different T cells or antibody drug conjugates, where they're delivering a drug via an antibody or a kind of a payload. I think this will be a big piece of what we do in all cancers, prostate cancer included, and this is kind of in the early stage of things in clinical trials. We're looking at obviously different targets the more that we're finding out what the genetics of cancer and prostate cancer included. There's a question about how you sequence it or combine some of these therapies, as I kind of talked about. And then, as I briefly mentioned, can PARP inhibitors be used in patients that don't necessarily have a genetic abnormality? Whew. So I know that was a lot of talking. That was a lot of information. Are there questions that you guys have?
I do have some questions here for you.
Okay.
The first one is, with so many Gleason scores increasing, for example, from 6, 3 plus 3 to 7, 3 plus 4, has there been any thought of adding a third component to the Gleason score to identify the very small cancer cells that aren't prominent but may grow over time?
You know, that's a good question. I think, to be honest with you, I think that the Gleason score is probably something that will be fairly concrete, but I think what will expand and is an ongoing question in prostate cancer amongst other cancers is really developing more of a personalized approach. So talking about the genetics or looking at the genetic subtype of cancers. There's actually been some interesting data. So we risk stratify early stage prostate cancer based on some features, which incorporates Gleason score. Some includes some other high risk features, whether that be lymphovascular invasion, a high PSA. But there's actually this artificial intelligence that's being developed and potentially used in the future in terms of really trying to analyze a whole plethora of different patients and trying to spit out, so to speak, a risk score that you ultimately can have. So I think that more so than the Gleason score, I think that we're probably developing a smarter way or approach and a more personalized approach of how we view or risk stratify prostate cancers.
All right. The next question, what goes into your thought process when you decide how long a patient should be on ADT?
You know, that's a great question. I'd say if we're it's all about context and ultimately what the patient values. So as I briefly spoke about, I think prostate cancer comes in all sorts of different flavors, some that's very well behaved, that we have the luxury of maybe stepping back some of the therapy with respect to a focus of quality of life. I think in early stage disease, we talk about therapy after a local treatment, typically radiation. But if, say, a PSA rises without any evidence of any metastatic disease, it's not an unreasonable approach to do what's called intermittent ADT. That means treating for a period of time, giving a period off, and then resuming treatment. And there's been some data to say maybe there's a slight decrease in terms of survival or how long patients live, but there's been a big quality of life improvement. With respect to advanced prostate cancer treatment, unfortunately, you're a little bit stuck. Ideally, the ADT is continued longer term throughout the course of the rest of their treatment. But I describe treatment as a kind of a marathon to patients. So it's important, yes, that we get PSA results and hopefully scan results that look encouraging. But if they feel miserable, I'm not sure what we're really achieving. And I think there's this hard piece in prostate cancer to get so fixated on a number in a PSA, especially with metastatic or advanced disease, when men are frankly miserable. And I'm not sure why we're prolonging their misery. So again, depending on the aggressiveness of the cancer, we may kind of take breaks, so to speak, with this really being viewed as a marathon, not a sprint.
All right, the next question. Can Casodex be used by itself to block uptake of testosterone without ever using Lupron, Eligard, or Oravox to reduce testosterone production?
It's a good question. It tends to be a very weak drug. I think when we had limited tools, it may have been used, but not commonly would it be used alone. So again, in my practice, I typically only use it at the beginning of the shots that patients receive, and then they're kind of quickly tapered off it. And again, that's meant to blunt the effect of that initial testosterone flare. But it's a good question. It's to speak frankly, it's a lot cheaper than some of the other newer oral agents, as it's much older.
All right, next question. How long can ADT be used before osteoporosis becomes a concern? 6 months, 12 months, or longer?
It's a good question. Typically my threshold or bar is anything more than 6 months in terms of a treatment. But having said that, if patients have underlying comorbidities, other health conditions, or risk factors, it wouldn't be completely unreasonable to consider getting a DEXA scan to kind of evaluate a patient's bone health. I'm very much surprised in a lot of patients that have fairly minimal symptoms and actually have osteoporosis. So in that case, they would warrant some bone supportive therapy, even outside of that more accelerated process that would happen with ADT. It's a very, very good question. Typically 6 months.
Oh, okay. Of that timeline of treatment drugs you showed to be used for metastatic prostate cancer, how do you determine which one to use for a specific patient?
It's a good question. So I think, first of all, context, I'll emphasize, is a big role. So there's kind of really two buckets that you're talking about. Patients that are diagnosed with metastatic disease to begin with at diagnosis, and those that develop metastatic disease later on in ultimately their disease course. I think those are two different biologies. If a patient's young and fit, I may be more aggressive, offering 3 drugs at once to begin with, and then, to kind of tapering off. I think a lot plays into the tumor itself and the aggressiveness of ultimately the tumor and how the patient looks and ultimately what they value. So it really is, I know I keep emphasizing this, it should be kind of a shared conversation that you have with your doctor in terms of side effects ultimately and what you're trying to achieve or benefit.
All right, next question. If a patient has PSMA negative prostate cancers, is the older Axiom PET CT scan of any value to find prostate cancers?
That's a very good question. I don't think I've ever really run into that. Not to sound facetious, but I might think insurance might give you a hard time in terms of approving the 2 different types of PET scans. PSMA PET scans, we often have to really fight with insurance companies just to get. PSMA PET scans ultimately to end up being more sensitive than Oxymin, and Oxymin are, from what radiologists at least have told me, a little bit more difficult to interpret. But that's a good question. In that setting, a bone scan and a CT might not be an unreasonable option in terms of following it. And I think a lot depends, I guess, on a negative PSMA PET scan and what your PSA level is when you do it, meaning that sensitivity or specificity goes up fairly significantly the higher PSAs that you have. So that's important as to when you ultimately do a PSMA PET scan, which is a very controversial topic in terms of what that magic number is. Say if you have a slowly rising PSA of when you kind of ultimately do a PSMA PET.
All right, I have one more question.
Sure.
Some supplements such as vitamin D and calcium are supplements that are recommended. Are there any others? Melatonin, metformin? Question mark.
Nothing that I'm aware of. I often get asked by patients about herbal supplements, and I certainly caution folks in that those aren't as regulated as drugs that we prescribe. So we often worry about one of two things. We worry about potential side effects of something that is in there that they're not telling you, or two, how those supplements ultimately interact with the drugs that we're giving. And if you guys are interested at all about alternative medicine or herbal supplements, there's a great resource from Memorial Sloan Kettering called About Herbs. And it gives you all sorts of kind of detailed information about different herbs. So very good question.
That is all the questions I have here in the chat. Does anybody else have any other questions that they want to ask?